everyone, welcome to Digital Health News. And today we are recording yet another episode of DHN CXO Podcast. And we are joined by Wing Commander MK Bose, former CEO of MGM Seven Hills Hospital, Vizag, healthcare veteran. Has been in multiple healthcare institutions, has been in the army, and fantastic insights on how to bridge the divide between rural and urban healthcare. Thank you so much, sir, for joining us here on DHN Podcast.
Thank you, Aarti, for having me. It's truly a privilege to be a part of a conversation that addresses what I truly believe is one of the most defining challenges of our times. That is talking about bridging the rural healthcare divide through digital care. So when we talk about digital health, we often focus about innovation, we speak about technology, we speak about platforms, but the reality is far more different. What we find lacking in the rural healthcare is equity, most
Hmm.
important, accessibility, dignity of care, and continuity of care. These are the facts which actually truly define the difference between rural and the urban healthcare. And that is what
Hmm.
I think the digital healthcare can take care of. Because the
Correct.
realities on ground in the rural healthcare is far more different than what we can imagine. Having traveled extensively in the rural field while having served in many of these organizations, I've seen what is the realities on ground. And having seen that, I can still say that despite the fact that we can bring in digital healthcare, the distance we need to travel is very, very long. And unless and
Yes.
until we do this traveling earnestly, honestly, and with integrity, I don't think we can bridge the real divide. The
Correct.
choices we now make will actually define whether the digital health will become a true equalizer or will simply become a parameter that continues to reflect existing.
So, before we dive into the topic at hand today, why don't we map out your journey a little bit so that we also get a background and a context of how much of the rural area, and the rural healthcare you have experienced, and then we can take ahead from there. Why don't we start with a little bit of your background in healthcare, and then we will dive straight into the topic we are going to discuss.
Well, I have a total of 44 years of service, of which 22 years has been in the armed forces, that is the Air Force, where I was in the aviation side, that was in the air traffic controlling. And after 22 years, I took a premature retirement, and as it would be a divine intervention, I would call it, that I landed up into the healthcare industry. My first job was in an organization called Lepra, based in UK, works in 18 countries, and I was working here in Lepra, India, for about 3.5 years. From which lepra primarily works into vector-borne diseases and infectious diseases, starting from leprosy to other TB, HIV, and all of this. From there, I went on to work in LV Prasad Eye Institute because there was a background how I brought in the blindness
Hmm.
program into lepra because of my passion, what I saw in the field with regard to blindness.
Right.
And from LV Prasad, I switched over to Apollo Hospital as the CEO of Apollo Hospital in Karnataka. To came back to Hyderabad to work in another organization called Meristopes International, which
Right.
works in family and child healthcare. Then came as a CEO and director of Malareddy Narayana. Subsequently landed up in MGM Healthcare, which was MGM Seven Hills Hospital, which was earliest only a Seven Hills Healthcare Private Limited, with two hospitals, one in Vizag, one in Bombay. And unfortunately, the Seven Hills Healthcare Limited went into insolvency and it was taken over by the NCLT. And I was then the CEO. In 2024, MGM Healthcare from Chennai took over that hospital and the Vizag unit only, not the Bombay one. And I
Hmm.
continued to be the CEO there for about a year. And then after that, about 4 years being away from my family, I returned back to Hyderabad and continued to be here, thinking that I would take a retirement and continue as just a healthcare specialist, helping out people, organizations, institutions in various ways, what I can in my capability. But an Amor group of hospitals approached me and they said, why don't you join us and help us with your expertise? So I decided to join Amor Group of Hospitals from the 19th of this month as their Group CEO.
That's
That's
fantastic
the
to hear,
short
and
journey.
congratulations on the new journey, sir.
Thank you so much.
And I think even though we want to, have a retirement, whenever duty calls, we have to answer.
Yes, especially being in the man in uniform, and we still continue to have that feeling that whenever and wherever we can, we will continue to deliver services whenever required and whenever desired.
Let's dive into the topic at hand today. I want to start this conversation differently from how these conversations usually start. We talk about numbers, we name the platforms, we talk about the policy frameworks, but I want to start with something which is more basic, but which is something that you might have seen regularly on ground. What this
Yes.
divide we are talking about, the rural versus urban healthcare divide, actually looks like and feels like on the ground, because I think we have gotten very good at talking about it in numbers and perhaps not have been very honest enough about what those numbers represent in real lives. That brings me to my first question. When we talk about India's urban rural healthcare divide, we often reach for statistics: 63% of the rural population, 80% of specialist vacancies, half of PHCs not functioning round the clock. But behind every statistics is also a lived reality. From your experience, sir, what does this divide actually look like on the ground? And do you think we have been honest enough about its depth?
Well, I think to be talking about statistics is good. Statistics are usable and they are useful. They give us a scale, but the realities are far more different. They do not really actually capture, statistics do not capture reality, to be honest. And I, having traveled extensively into the field while in various organizations, I've seen those stark realities. So as I said, statistics, they only can give us a scale. That's good. They're useful at times to do some kind of an analysis. But what we see on ground is far more different. You know, on the ground, the divide is not abstract. It is deeply human. If we talks about the distance, when I say distance, I still talk about the distance that a patient or a person in the rural area has to travel just to get the basic health care, right? So we still face with those realities. The delay, when I talk about delay, the delay in terms of getting the basic healthcare, delay in getting the primary diagnosis done, getting to go to a PHC, those and getting the results in diagnosis, those are the delays I'm talking about that still exist on ground. And the most importantly, the difficult choices at times that these rural people have to make. Why? Because of affordability. They take a very difficult choice about going in with affordability or going in for the clinical care that is urgently needed. So many a times they go do away with the clinical need just because they cannot afford. So that is the stark reality. Because I'm talking
Right.
about patients still having to travel miles. I've seen them. If I give an example, I was in Bihar traveling, and when we came across a woman, you know, we were doing this basic survey in villages, and this woman came to me and said, I'll give you two examples. This woman came in to me and said she's a worker, laborer. Now to go to a microscopic center, she has TB. Now to go to a microscopic center to give her sputum, she has to catch a bus and go to that microscopic center to give her sputum. So she has to give away her daily wages,
Right.
afford that money to travel in a bus to go to that microscopic center, and then come back to go after 7 days when they have called her to get her the results, right? She
Right.
travels again after 7 days. And very nonchalantly, the person in the microscopic center says, your results are still awaited because the technician is not available. So you imagine the person, this is the stark reality. There are lack of technicians, lack of equipments. These are the stark reality. So these are the difficult choices at times. And the second example I was giving you, again in Bihar, there's something, a disease called leishmaniasis, which comes, where the spleen, becomes big, and I mean, it's a very dangerous disease, but government has taken
Right.
care that they can be treated very easily and free of cost in the government hospitals. So
Correct.
two kids came across to us with this disease of leishmaniasis. When we told their father to take these kids to the area hospital in Bihar, he refused. Why? Because he's going to lose out his daily wages. So these are the difficult choices that people make at times in the rural area, where they have to take those difficult choices whether to go in for giving up the daily wages or to look after their primary need or the urgent need of clinical. So this
Right.
family choosing affordability over necessity of clinical
Hmm.
need is a stark reality that still exists on ground. So the urban rural divide is not merely a gap in infrastructure. It is not a gap in funding. It is a gap in
Hmm.
assurance, continuity of
Correct.
care, dignity of care. And this difference of continuity or the dignity of care is the real divide that exists. Because in rural India, healthcare is still episodic and
Hmm.
reactive,
Correct.
right? But wherein in the urban side, it is still continuous and preventive. So there are two extremes. One
Right.
side, there are parts of excellence. In the other side, there's a huge gap staring at our
Hmm.
face.
Hmm.
There are PHCs which barely function because there is no human resource available. They are working from a dilapidated site, ramshackle, infrastructures. Okay, where not much of equipments are available, facilities are available for even providing basic healthcare. Because PHCs are the heart of any rural healthcare. They are the heart. But if you see and visit most of these PHCs, you'll find them in such conditions where the
Right.
system barely functions. They are,
Hmm.
and on top of that, they are overburdened because PHCs are supposed to be the referral points. They don't become
Hmm.
the referral point; they become subcenters.
Hmm.
On the ground, what happens? It manifests into delayed diagnosis, avoidable complications, and a constant compromise on the quality of care.
Right.
Right? So these are the facts of life. And that absence of continuity, that lack of follow up in chronic care management or diagnosis or intervention is where the real gap lies. Because
Right.
preventive care, follow up, chronic diseases management is very, very weak, still very weak in the rural area. As you spoken about being honest, we have not
Hmm.
been honest about it. Because if you have to be honest, then we have to acknowledge. I'm talking about we means we, all of us. We are a part
Hmm.
of the system. We have to
Yes.
acknowledge that it requires confronting systemic gaps, workforce planning, infrastructure, governance, not planning, not just funding. Giving funding and making an infrastructure will not help because it is the man behind the machine that matters. So unless and
Correct.
until we have trained manpower, I'm not talking about specialists, super
Hmm.
specialists going, but these frontline workers that we were discussing, they have to be trained. They have to be,
Right.
made aware. They have to be,
Correct.
made so much confident about taking care of patients that they can. So all these things has to be taken care of because urban India has
Right.
availability and choice, whereas rural India still struggles with access and adequacy.
And I
The
think that's
divide,
the thing.
yeah,
Yeah.
because I would
I
say
think
that it's a divide between reliable versus unreliable. It's a divide
correct.
between reliable versus unreliable. In
Hmm.
until care is connected, until care is consistent and close to the patient, the divide will remain,
Right.
no matter how
And I
many
think
facilities you
right.
build. Tell me.
And I think that's the thing, sir. The moment you get out of the spreadsheet and into the story, I think the weight of it changes completely. What you
True.
described just now, that gap between what's on paper and what someone actually experiences when they need care, especially in the rural setting, I think that's the honest starting point for everything we are going to discuss today. So let me stay in that human space for a moment because there's a layer of the story that I think gets almost no airtime. One of the most under discussed challenges is what happens at the front line. Ashas, ANMs, PHC staff. You already mentioned about the dilapidated conditions of the sites, how the staff is treated, how the staff is overburdened. But they are the ones who are expected to run the teleconsultations, manage the digital records now, and assist the patients. And that is also often without adequate training or incentive. How do we fix what is essentially a human infrastructure problem and not just a technology one?
See, if I may say so, this is fundamentally a people problem and disguised as a technology problem. You're
Hmm.
talking about, but it is fundamentally a human problem or a people's
Hmm.
problem. Our frontline workers like the ASHAs, ANMs, the PHC staff are carrying the real weight of this transformation. Today, if we see these ASHAs, ANMs, the healthcare workers, all of them, they're expected to do a hell of a lot of work. They're supposed
Yes.
to deliver care, manage data, operate digital systems, educate patients, whole lot of work. Think about an ASHA worker today. She is expected to mobilize communities, track maternal and child health, and also manage digital entries because digital health is coming, assist with teleconsultations, sometimes even troubleshoot devices.
Yes.
But all of this is happening without adequate training, support, and last but not the least, incentives. If we talk about these frontline workers, India has over 1 million of ASHA workers. If they don't adopt to this digital health will not scale.
Mm.
Right? In many programs, up to 60 to 70% of the frontline workers' time can go up to just looking after this digital health documentation process, which is taking away most of their times. And they're not well trained about it till now.
Mm.
Right? Because training, what happens is a one time event there. And you can imagine that one time event of a training will not suffice.
Correct.
Right? So the last mile of healthcare isn't the location problem or the infrastructure problem or the technical problem. It is a problem of a person or a person's training needs. So if we have to expand, we have expanded expectations a hell of a lot, right? But not the capacity. So unless and until we build their capacity, how do you expect them to perform, right?
Mm.
We have
Mm.
added digital responsibilities without reducing what their existing responsibilities are. Their
Right.
existing responsibilities continue, but their added on responsibilities without adding to their capacity. And not always the capacities or incentives are matched with what they can perform.
Mm.
So if you add responsibility without adding capacity, what do you have? What happens? You create fatigue. You don't create transformation. And that is what is
Right.
exactly happening in the rural area. Technology
Right.
actually should ease their work and not complicate it, right? So to do that, I think we need to take care of a few things. First is we need to take care of their training.
Mm.
And training, by training, I don't mean one time training. It has to be continuous, repetitive, and on ground so that
Mm.
the training gets embedded into the system. They know how to perform in different scenarios, how to take care of digital health, how to take care of teleconsultations in terms of linking up, how to manage antenatal mothers, how to give free consultations and counseling to patients. That should be well defined in their role of training, first.
Right.
Second is the role has to be very clearly defined. What each
Mm.
individual is supposed to do, that role nobody is defining. Nobody is
Correct.
defining their role. They're just going about their own way of performing whatever they can. So the
Mm.
role has to be clearly defined what each individual is supposed to do and how much, so that they
Mm.
can perform creditably and efficiently and effectively. That is the most important. And thirdly, we need to give them incentive.
Mm.
I'll bring about the Maslow's theory of hierarchy, right? We know that in the lower echelon, what happens to motivate people. So
Yes.
such people needs to be given such kind of an incentive, and unless and until that happens, they will continue to bypass the system. So financial or non-financial, they have to be incentivized because what get measured and rewarded always gets done.
Correct.
Right? So
Right.
it is most important to strengthen the frontline worker because digital health will not scale unless and until we take care of the last mile or the frontline workers, the ASHA, the ANMs, and digital health. Because technology will quietly enable, but they will visibly burden if you don't actually train them. So that is
No,
my
I
take.
think you are absolutely right because you can train someone to use an app in a week, but you can't exactly train someone in a week to feel like the system also sees them as a professional rather than just a delivery mechanism in a larger scheme of things, right? That's a much deeper problem that we have to solve. We cannot just hand over the technology to the frontline workers like ashas, ANM, and phc staff and then expect them to do the registration, to do the data entries without the proper training and capacity building. Also, there has to be system, as you rightly mentioned. I think that is the approach that we have to take, and collectively we have to think about it, which brings me to the platform problem that we are going to discuss, right? I mean, we can talk about the training part, but the platform part is also as much important. Digital health has been positioned as the great equalizer. Telemedicine, ABDM, eSanjeevani. We are talking about AI in diagnostics now. We are talking about agentic healthcare. We have built significant platforms, and yet the fundamental problem, which is the access to the healthcare, has improved, but adoption has not followed at the same pace, which is something you also touched upon at the start of this conversation. Now, why do you think that gap is so persistent, especially at a time when the smartphone penetration in India is at a much higher level, right? You can see smartphone in the hands of people who stay in the rural areas. We have been able to get the smartphone to the last mile person, but we have not been able to ensure the access of healthcare to them.
See, the uncomfortable truth is that the digital health was never going to be a plug and play equalizer.
Hmm.
We have treated a technology problem when in reality it is deeply a human system problem. We
Hmm.
have built problems, but we haven't built habits. And
Hmm.
habits by meaning is, again, I come back to that same thing, how to use this system effectively. Access has certainly improved. We know that
Hmm.
telemedicine, and especially in the national digital health mission, the strong technological frameworks are there, but adoption is completely a different question. The
Right.
gap persists because technology was introduced as a solution, not as a
Hmm.
part of a workflow design. Digital tools have often added to their effort rather than reduce it. Patient, and most importantly, patients still trust the physical presence, the person who is using that system over the virtual assistants. So we
Right.
still haven't, made people aware how the digital health is going to help them. So the patient on ground and the person using the system both trust each other physical. The physical presence is more trustworthy than the technical, right? And as I said, the last mile, lack of hand holding. So instead of asking why are people not using digital health, we should be asking where is the gap? Where is the gap because of which the people are not using digital health? If we can ask this, the root cause analysis can be done. So the
Hmm.
issue is not access, the issue is trust, relevance, and ease. We have built strong platforms, no doubt about it. The
Hmm.
Ayushman Bharat digital mission is a very, very strong platform. The eSanjeevani, which is a teleconsultation, is a wonderful platform. But just building platforms will not work. You have to make
Correct.
people aware how to use it effectively, efficiently, and proficiently, right? So we have been designing for compliance. We need to design it for convenience. And this gap exists because compliance is okay. You just tell them you need to do this. But that will not happen. We need to tell them how convenient this system is going to be for your healthcare, right? Unless and
Hmm.
until we do that, it will not help. So designing for compliance is not going to be effective unless and until we design for convenience. And the gap persists because the digital literacy is low. The
Hmm.
trust in virtual consultation still hasn't happened because we haven't made effort to make this reality. Poor integration into the clinical workflows, and as I said, absence of incentives. If those things continue, this will happen. So adoption will accelerate only when digital tool becomes an enabler,
Hmm.
invisible enabler, and not a visible
Correct.
burden. As of now, digital health appears to these frontline workers and the patients a visible burden. So many documents to fill, so many things to be incorporated into the system, so many number of systems to manipulate and navigate. Very, very difficult for them. So digital health should become an invisible enabler, not a visible burden. It should tell them that it is going to save time and reduce the number of steps that we put into these systems. The number of steps patient, I have seen it in corporate hospitals. You know that when you ask a patient, fill up this form, they are reluctant to fill up so many things. They want to quickly get an access to a doctor. Even a
Yes.
doctor is at times reluctant to fill up a form. So how do you
Hmm.
expect this to happen in the rural setup? So
Correct.
I would say that the access is a milestone,
Hmm.
whereas access is a milestone, but to adopt, that is a mindset. So we have to change the
Hmm.
mindset. The milestone has been achieved, but the mindset has to change. And digital health should help in reducing friction,
Hmm.
improve the outcomes, build trust. Then adoption will come in. Otherwise, adoption will remain uneven.
And that's,
Adoption
I
should
believe,
not
a
feel.
really important distinction, sir. The
See,
milestone versus mindset. I mean, we have ensured the access part of it, but the mindset shift is yet to happen. And it also has to be convenient for the frontline workers who are implementing it than making them feel like more compliance adding to their existing burden. And I
absolutely.
believe the gap is not just implementation, but it is actually design, as you mentioned. Then in that process we have a bigger rethink ahead of us than most people are sort of willing to admit in this course. Let me That brings me to my next question. The response to low digital adoption in rural areas has often been to build more apps and more platforms. Now, should we be rethinking the design philosophy of digital health tools entirely And what would truly inclusive design look like in the Indian context?
I believe it must fundamentally rethink. We have to fundamentally rethink how this design has to happen, especially to assist the rural setup, right?
Hmm.
At present, many of our tools are designed for the urban,
Hmm.
digitally comfortable user, not taking
Yes.
into mind as to how a rural person is going to use it. So, at the moment, the design is completely misplaced. I would say this,
Hmm.
taking into cognizance this fact that what is the capability of the person using that in the rural background. So we are designing it for the urban and the digitally well-equipped user, but not taking into cognizance the fact whether it can be comfortably used by a person in the rural setups.
Hmm.
So we design for the urban user and expect the rural person to adopt it. The shift required for it has to be very profound. Design for the context, not for
Hmm.
compliance. We have to contextualize this whole thing. We have to ensure that the system that we design for the rural setup, it should be done in a local language, vernacular language as they can call it, the
Hmm.
dialect part of it. Minimal complexity has to be there in
Hmm.
the design, and the systems that work even when connectivity does not exist, because if all that is there, they should be able to continue with the job even if there is no connectivity, and subsequently when the connectivity comes they can start reusing it. So we have to have an inclusive approach where both the urban and the rural can help, right? Especially the
Right.
rural when we are trying to bridge this divide. So the designing for the least digitally comfortable user and not the most advanced one is what we have to keep in mind. So we
Correct.
have to keep this simple, intuitive interfaces where the tools are not so much complex. It should be low literacy friendly, fit into all their workflows that they're doing on a day-to-day basis,
Hmm.
built for an unreliable environment where it can work with even a low connectivity. All of this has to be. So,
Hmm.
because if we are going to, overload the front line, he is going to bypass the system,
Hmm.
and then we are not going to achieve anything. It should help the technology should help them, not make them stagnant. Because
Hmm.
inclusion, when I talk about inclusivity, inclusion is not about access. It is about usability in the context, right?
Hmm.
So the best system is not the most advanced, it is the most usable. So
Hmm.
that is where the design change has to happen, keeping in mind the context, how a
Correct.
rural person can effectively, efficiently, proficiently use it. Not
Hmm.
keeping in mind, they're designing at present for the urban setup and expecting the rural to use it. It cannot happen. And especially when they're
Right.
not trained, well trained on the whole system.
And in fact, this is one of the less talked about problem. Do you think that who is in the room while building these kind of solutions for the rural population also matters? I mean, you cannot design for a reality you haven't lived or at least genuinely listened to.
We have to take them into the foray to understand what their needs are. We cannot keep them secluded and think on our own way and design a system. That's what I said, an inclusive approach. When I said an inclusive approach, I mean they also has to be brought into the foray of this entire discussion. What do they require? What are they comfortable with? How much can they access? How much can they use? How much of a training they require? What is good for them? If these discussions do not happen with them, they are
Right.
not included into the designing process, system, then these gaps will never get merged. These gaps will
Correct.
continue to persist.
Mr. Bose, there is a view gaining ground in India today now that India is also progressing in terms of, rapidly evolutionizing the digital health ecosystem. We have our own digital health stack now. And not only digital health stack, but India is also building its own, digital public goods, digital infrastructure. With that, there is a view that is gaining ground. The digital health infrastructure should be treated as a core healthcare infrastructure on par with the roads, power, water, etc., and not as an auxiliary service. Now, from your vantage point, what needs to change in terms of policy, budgeting, and the mindset for that to move from sort of aspiration to reality in the next few years?
I would say that this shift is just not desirable, it is inevitable. Because if we want to bridge the gap, this shift is a must. I would say that this is just not realistic, it is also necessary and inevitable in the near future, right? So though we are doing all this, we are still not there as yet. Because still treat digital health as a project and not as a public infrastructure is where we are lacking. We
Hmm.
start seeing digital health as an optional innovation. No, it cannot be an optional innovation. It has to be a force multiplier. Because for every healthcare intervention, we have to think that it is going to be a must and a continuous thing. We cannot keep it as an option. Okay, you can use it, you may not use it. No,
Hmm.
it has to be a must. So that's what I think, that this shift is inevitable. It must be
Correct.
seen as a core infrastructure, no different, as you mentioned, from power or roads. Do we
Hmm.
build a road and say that, okay, you may use it, you may not use it? Roads are always built because you have to use it, because
Hmm.
it is necessary for those roads. So similarly, digital health has to be built in such a way that it becomes a must for everybody to use it. But I have
Correct.
spoken about this before, how we need to build it. When we build it in such a way that it is
Hmm.
usable. And usability will come only when the frontline workers are taken into. There are three things that we need to take into cognizance for making this shift as a must and it becomes successful. How do we make this there are three things that comes into foray, I would say. First is the policy conviction, sustained investment, and we cannot take this as fragmented pilots. To make this shift,
Hmm.
digital health must be embedded into the national health system, that it is used everywhere, not treated as a pilot. If we treat
Hmm.
this as a pilot innovation, it will not succeed. It has to become a successful policy integration into our healthcare system nationally. Only
Hmm.
then it can be implemented both urban and rural. As of now, we do not have such integration. Nobody bothers whether it is getting integrated. They just build systems. National Digital Health Mission has been made. eSanjeevani has been made. Whether it is being effectively used, not used, there is no such policy. So we need to
Hmm.
integrate this into a policy, right?
Right.
So healthcare infrastructure is not as a, it cannot be just as a bypass, it cannot be just as a pilot, it has to become a must. So policy still tends to give it as an enabler. That means we need to clear mandate for interoperability.
Hmm.
Very importantly, accountability for usage, not just creation.
Yes.
Once we build it, we have to see that there is an accountability of it being used, right? Because infrastructure is what you build and it is reliable only when it gets used. Second is dedicated funding. Yes, we have built
Hmm.
these digital health missions, eSanjeevani, but we have to give dedicated funding. It is not as one pilot, once funded, forget. It cannot be treated as a capex. It has to be treated as an opex.
Hmm.
Continuous funding for maintenance, for built up, for cyber security. All of this has to be taken into account when we do this. So funding has to be continuous. Only then it can
Right.
be sustained. And the last is the mindset change. We stop
Hmm.
seeing digital as an optional innovation and as an add-on. It should become a force multiplier, as I said. For every healthcare intervention, digital health should come on as the first line of intervention. Only then it will
Right.
be useful. And
Hmm.
it should be treated not as a project-based funding, but as an operational expenditure. So
Hmm.
from CapEx, we have to shift it to OpEx.
OpEx. Right, right. If I may add a follow up to that, is there any governance model that exists, maybe from another country or even another sector within India itself, that you would point out to as having got this framing right? Because even if we have US healthcare, which is heavily digitalized, we have NHS from UK, I think for any such intervention to succeed in India, it has to be heavily contextualized from Indian perspective.
Absolutely, because that's what I said. A policy intervention has to happen. Before this, I spoke to you about inclusivity. So,
Hmm.
unless a policy integration will happen only when we have an inclusive approach, we have to take into account how much it can be used in the rural setup and how much it can be used in the urban is not a problem. Plus, they
Hmm.
have various models in the urban. But when we talk about a national integration, I talk about national integration wherein the policymakers has to get involved into this.
Hmm.
Just documenting will not help. We have to see to it that it gets implemented on ground. And to get
Hmm.
implemented on ground, we have to travel the mile. When I say travel the mile means people have to go to the rural, interact with them, try and understand what their needs are, what are the
Hmm.
infrastructure requirement. When we plug all these gaps and then infuse this system, then all it will work absolutely parallel in both sides in terms of urban as well as rural. And the rural has to be connected to the urban setup. Unless and
Correct.
until the rural is going to get connected to the urban setup, the patient referral, as I said, PHC basically should work as a referral system, right?
Hmm.
But PSCs are, as of now, are working as sub-centers. So these things should not be happening unless and until we bridge this gap by digitally connecting both of them, by empowering, understanding, implementing it effectively on ground in the rural area through a policy, and by not just documentation, by ensuring that this implementation happens by the government, both central as well as state, taking into account also the private people, then only these things will improve.
Right.
Because a public private partnership is also a very important factor in this,
Correct.
because today nothing can work in a silo, right? We have to
Hmm.
have a coordinated effort. So as much as the public means, I mean the government intervention, the same thing has to be from the private. They both have to
Right.
come together to ensure that these
Hmm.
things are equally connected. As of now, we are working separately for urban and separately for rural.
Hmm.
So a
Hmm.
policy integration is must, but just not mere documentation. It has to be seen that it is effectively implemented on ground by these policymakers only. Only then it will succeed.
Yes, I believe while we also try to fix the interoperability problem and try to fix the fragmented ecosystem in terms of technology, that same effort has to be done on the policy side as well to connect the human ecosystem stakeholders in this process. And that strikes me in the everything you have said so far: the frontline worker problem, the platform design problem, the infrastructure problem. They all share a common thread, which is the people closest to the problem have the least power to fix it. And that tension sits at the heart of what we are discussing. Let me push into some harder territory now. Health tech startups have shown genuine promise. There are startups who are working to solve this, digital divide and the urban-rural health tech access divide as well. In teleradiology, we have seen startups in AI diagnostic, mobile clinics, but the pattern is familiar. They have strong pilots, but they have weak scale, fragmented procurement, and no outcome linked contracting, poor integration with public systems. In your view, what is the single biggest structural fix needed to move promising pilots into sustained programs?
First and foremost, we need to understand that pilots are not the goals. Outcomes
Hmm.
are the goals, right?
Yes.
So that is where the first misplace is. We think
Hmm.
pilots, by ensuring pilots, things are okay. No, we have to understand that outcomes are the is our goal. What are we
Hmm.
going to achieve by instituting these pilots? Unfortunately, we still are treating innovation like an experiment and not like infrastructure. We fund pilots, but we don't fund outcomes. We have to be outcome based funding. The single most important shift would be link payments to outcomes and not activity.
Hmm.
That should be our first shift and major shift that needs to happen. Only then things will improve and the pilots will scale. Once that happens, scales will automatically happen. The
Correct.
single biggest structural shift required is move from input based outcomes to outcome based contracting. Do not fund for inputs, fund for outcomes. Only then things will improve. Otherwise, it will not. We are only funding for pilots.
Hmm.
And we should go in for
Correct.
outcome linked, as you said, multi year contracting. Because
Hmm.
everything else is fragmented, pilot fatigue, poor integration largely flows from these design flaws. We should be buying activities only when they can tell us how many number of scans done, the number of
Hmm.
deployments have happened, but we are not ensuring that what is the impact of this. We're not seeing the
Hmm.
impact. So unless until we have an impact analysis, things will not improve. I mean, healthcare doesn't improve by doing more. It
Hmm.
helps and it improves by doing better. So I
Yes.
would say all these pilots should right now, which are running for a 6 months, X number of devices, Y number of patients, they're only going by that. No, it should not be. We should make sure that these pilots run for minimum of 3 to 5 years.
Hmm.
Contractualize them in minimum length of 3 to 5 years.
Yes.
Outcome tied, not volume tied. So many number of patients. Never have believed when I talk to my people in the marketing field, I'll tell you. I don't tell them, don't tell me how many number of meetings you have had. Tell me how many number of patients have been empowered, how many number
Hmm.
of patients have come, how many number of patients have been treated. So same, that is the outcome, because
Yes.
outcome and then the impact will happen. Because right
Hmm.
now numbers do not tell us the real story. It should not be a standalone pilot. We should also, today we are only paying for devices deployed, software installed, all of this. No, the payment should be linked
Correct.
to consultations, number of consultations completed. How has the diagnosis improved? Has the
Hmm.
diagnosis improved or not? What is the health outcome? Whether we have achieved the parameters of the health outcome that we have set, the
Hmm.
indicators, are they showing us? Has the referral times being reduced? Has
Right.
the improved disease detective system happened or not? So better patient outcomes are the most important factor on which the payment should be linked. When these things happen, pilots will automatically scale. So
Right.
align incentives to these people with outcomes. Because
Hmm.
accountability improves, innovation becomes meaningful, and scales will naturally follow if these processes are followed.
When we
So
talk
bottom
about
line,
this,
I
sir,
would say, is not a technology problem, it's a funding problem or a
correct.
procurement design problem. We have to set that
Hmm.
right. Procurement
Hmm.
design problem is what it is. So stop paying for effort and start paying for impact.
Hmm.
We will automatically see transformation happening. Because healthcare
Correct.
transformation won't come from what we pilot. It will come
Hmm.
from what we choose to scale, measure, and pay for it. We have to clearly define this to those people who are piloting this. If
Right.
we can do that, certainly we'll achieve much.
Definitely. And I believe everybody who talks about this problem statement, this is the suggestion that they have. But the problem is who will move first? I mean, if you
The
had to
government.
name one actor, whether the government, the investor, or the hospital system, who needs to move first to break that cycle, who would it be?
The government and the, as I said before, the government has to be the first one who has to take a
Hmm.
step. The central, the state, the district administration, and then comes the public and the private,
Correct.
right? So
Correct.
first the government has to show this. I'm sorry to say this. The government has to show that initiative in ensuring that whatever we do is a long-term plan. It's not a short-term
Hmm.
plan. Just to show
Right.
that we have done this and forget about it. No, it has to be a long term plan, effective. There has to be a positive outcome of it. We have to show those outcomes. We have to analyze it from time to time. And then only we can measure, are we progressing or we are stagnant. So the government has to
Correct.
first come in, implement it through the state government, district administration. They have to get deeply involved. And then we can ask the private to help us out, in scaling it up further and further, because the
Hmm.
vendors are very happy in just supplying and being happy with it. So
Hmm.
they are just supplying what they have been asked to supply. So we have to
Yes.
lay out the clear terms and conditions, and that has to be done by the government, because
Correct.
health is a government issue.
Well, thank you so much for that. Uh, Now, there is a layer beneath the structural one. We spoke about the structural problems in the healthcare adoption and bridging the rural and urban divide. But there's also a layer which is beneath the structural one, and it's the one that gets treated as soft when it's actually the foundational layer that needs to be addressed first, which is the trust. It's one of the most underrated determinants of digital health adoption, especially in
Yes.
underserved communities. We have data misuse concerns, consent without comprehension, language barriers. How do we build trust into the architecture of digital health, not as an afterthought, but as a foundation?
See, first and foremost, trust, as you said, is the most underestimated variable in this entire conversation of ours, right?
Hmm.
People are willing to engage in the rural setup, but only when they
Yes.
feel informed, they feel respected, and they feel
Hmm.
secure, right? Because trust in the rural setup is not transactional, it is
Hmm.
relational. They trust people more. They will not trust a system. So trust is the foundation. Without it, nothing can scale. And I have seen this. They will trust a quack. They will trust a RMP, but they may not
Hmm.
trust, because the way we build that trust, day to day life is what is most important. If they feel that their data is not secure, how the data is getting used, they will never trust that system. They trust people. And in healthcare, trust is not a feature, it is the foundation on based on which the healthcare is standing in the rural setup. So trust must be built into the architect itself of the platforms and the system that we wish to integrate. So the trust must be built into the architecture itself. There should be clear, understandable consent. When they give a consent, they should understand what is that consent that they are giving. What is it meant? How is it going to help them? The communication has to be done in local languages. You
Hmm.
cannot put some high-flown languages, technical. When I say, I'm not talking about English or any other language, I'm talking
Yeah.
about simple terms, not
Hmm.
technical jargons. If it has to be used, then they will never trust. Then this transparency about the data usage. They must know what is this data that they are taking, we are taking from them. How is it going to be used? Is it going to be beneficial to them, or that can get misused? Because nobody is willing to part with their data unless and until they know. We are ourselves skeptical about giving us our Aadhaar card and PAN card to somebody. Why? Because we feel that this can get misused. So they are also the same people. If they have to give their family history, that everything, they should know that this data or whatever they're talking about, their own disease, the genesis of their disease, it is
Hmm.
going to be absolutely protected, secure. So
Correct.
that transparency has to come in, and the trusted human interface has to be there the last mile, because people must feel safe. They should not feel insecure. They should not feel confused. They should not feel coerced into whenever they're interacting with the people on ground at these centers. Trust must be
Correct.
designed into this architect. We should not
Hmm.
assume that okay, they will come and trust us and we will go ahead with this. No, trust has
Hmm.
to be designed, not assumed. So, because ultimately access is important, but trust drives adoption. Unless and until they trust us, adoption will
Hmm.
not happen. It will
Correct.
remain where it is.
Hmm.
So, because this fear of data misuse, the language, consent, so all these things prevent them from adoption also. So
Hmm.
adoption will increase only when trust happens. So we must ensure that these trust is designed to the
Hmm.
systems, and they are not so technically jargoned or sounded that they don't feel themselves distant from what they are
Hmm.
interacting with.
Yes. And I think we should definitely aim for the informed consent and not for the comprehended consent. These are not the same things. And especially with the onset of artificial intelligence, we are not now talking about, infusing AI into the clinical workflows. This distinction becomes more prominent than ever. As I mentioned, AI is increasingly now being presented as the answer to the rural healthcare's most complex problems. You talk about the early diagnosis, clinical decision support, continuous monitoring. But alongside this promise, there's a real risk. We are talking about the algorithmic biases, the data quality gaps, accountability vacuums. And these are not just the perceived risks, these are real risks that exist in the healthcare workflows today. How do we ensure that artificial intelligence in rural healthcare strengthens this equity that we are talking about rather than deepening the very disparities it sort of sets out to solve?
See, AI holds tremendous promise, but it also carries a lot amount of risk. AI can either democratize healthcare or it can deepen the very inequities we are trying to bridge. AI
Hmm.
is powerful, no doubt about it, but it is not neutral. AI goes by what data is being fed to them. And if the data is skewed, obviously
Hmm.
bias will set in. So AI doesn't automatically create equity. It can just as easily scale existing bias unless and until we are careful about what the data is being fed, right?
Hmm.
So if the AI is being trained on biased data or deployed without any context, it can reinforce the very inequities we are trying to solve today. So we have to be careful how we use the AI. As of now, I feel there are three structural gaps from where the risk actually comes from. First is the biased, as I talk about, or
Hmm.
incomplete data. And rural population, mind you, has a lot of these incomplete data. So we have
Yes.
to be careful. Recently when I had gone for this AMR convention talk in
Hmm.
Mumbai, you know, for how the AI is being used for these antimicrobial resistance drug to be built. Because as of now, what humanly we are building up is through the data that we are collecting, trying to analyze, and it is humanly impossible. So we are trying to take the help of AI to build these drugs through the
Hmm.
AI. But AI will only give you a drug based on the data that is being fed to them. So if the
Correct.
data is not complete, if the data
Hmm.
is skewed, AI will give you a analysis which is biased. We can't
Hmm.
help it. AI is just a machine, and as I said,
Hmm.
this is the man behind the machine that matters. What we feed is what we get. So poor data quality is the last mile, and unclear accountability, because people should not say, "Oh, I have fed the data and I've forgotten about it." There should be an accountability amongst those people who are feeding those data, who are collecting those data, to feed it into AI for AI to give us, that kind of an analysis by which we can go ahead. So the
Hmm.
accountability has to be fixed. So without addressing these, AI can widen the very gaps that we are trying to fight, or we are
Hmm.
trying to, bridge. So to
Hmm.
ensure equity, we must focus on train AI on diverse and representative data, They should integrate with the frontline workers, means the data that we collect should be absolutely ratified by the ASHAs, the ANMs, the frontline health workers, because they are the people who have got the actual data, because they are the people on ground who are interacting with the rural people, nobody else. Just by collecting some data on paper will not help. So we need to integrate with the frontline work and maintain human oversight over the decision making. We should not
Right.
leave the entire decision making on the AI. AI is
Hmm.
help to reduce the burden, not
Hmm.
replace the complete system. AI should not be allowed to replace the complete system
Hmm.
or override the complete system. AI should
Right.
assist, you know, it should help in decision making. So
Hmm.
establish clear accountability and constantly, I should say, audit all these data that we get. If we don't audit, then we will land up in trouble.
Hmm.
So AI must augment the weakest link in the system, not optimize the strongest.
Correct.
It should not
Correct.
replace the judgment and decision making. It
Hmm.
should support the clinical judgment. Today we feel that AI will take care of everything and we can sit back and relax. No, it should not happen. Humans should not get replaced.
Hmm.
Human interface has to be there. AI should only help in assisting us. The data that
Correct.
we get should help us in making a judgment. We should not
Hmm.
leave the AI to make the complete judgment. So
Right.
I would say AI should not just make a healthcare smarter, it should also make it fairer. That's how AI should be used.
Mr. Bose, taking a thread from the point that you just mentioned, if done poorly, digital health sort of also risks becoming a parallel layer that mirrors the existing inequities rather than dismantling them. That's the whole idea about digital health, right? To dismantle the existing equalities to become a great equalizer of sorts. But if we don't do digital health properly, if we have some sort of errors in adoption of digital health, it eventually ends up becoming a mirror to the physical healthcare ecosystem. In that sense, are we on the right track when we talk about digital health adoption? And if you could mandate one policy priority for the next phase of India's digital health journey, what would it be?
See, I would say that we are on the right track, directionally right,
Hmm.
but not at the right pace,
Hmm.
not in the right discipline. So
Correct.
operationally, we are still a lot to achieve. Direction is fine. We are directionally correct. But operationally, we still have a lot to, we have to bring in a lot of discipline and a lot of depth in whatever we are trying to achieve. So India has
Yes.
built some very favorable, platforms through, as we have been discussing this over and over again, digital health
Hmm.
missions, Ayushman Bharat or eSanjeevani, all this. But infrastructure alone doesn't guarantee equity, isn't it? We have to be
Yes.
careful that digital health should not become a parallel layer. So
Correct.
we must prioritize interoperability and accountability. That has to be taken care if we have to ensure that this digital health does not become a parallel system to the existing one. Digitally, we should enable my point here is to ensure this to happen. I personally feel, this is my feeling because from the way I have gone about seeing this, that the primary healthcare center is the most important place. And the digital health should primarily first be instituted in the primary healthcare center, in all
Correct.
the primary healthcare centers. They should be digitally empowered. And it should not be done as a pilot, not as a
Hmm.
standard. It should be done as a baseline. All the primary healthcare centers should be digitally enabled, right? And every PSCs in the area around should be interconnected. They should be not only enabled, but they should be ably connected. Supported. When I said supported means they should be supported through maintenance, supported through funding, supported through technical support. All of this has to be there. Only then
Hmm.
these PSCs will constantly function. Because primary care or the primary health center is the place where the primary equity begins. If we neglect primary healthcare center and concentrate on the area hospitals and all that, it will not function. So we have to start from scratch, and that is the primary health centers, because every system must talk to each other. Every system,
Yes.
and I mean is every primary healthcare centers should be able to talk to each other. What kind of a patient are they getting? How are they, collecting the data? What is the disease interventions there? What is the disease prevalence there? All these things a human mind cannot, contextualize, neither document it manually.
Hmm.
Digital health will improve that. So the real risk will happen if the mirror of existing inequities is not taken care of. Access will remain uneven, design will exclude the user, and implementation will remain fragmented. So the
Correct.
PHCs needs to be connected well. And these data which are available in the PHC should be accessed by the area hospital within
Hmm.
seconds,
Right.
isn't it? It should not. They should, so that's what I said. Not only are the PHCs to be interconnected, they should be connected with the area centers,
Area.
sub centers, and in the so that all this patient data can be quickly accessed for when the patient comes there,
Hmm.
so that the patient's treatment is absolutely even. So, if access, literacy, and trust gaps are not addressed deliberately, the risk of inequity persisting will be significant, because
Hmm.
digital system doesn't correct inequity; they replicate it unless and until we are careful about it.
Absolutely. And I think that's the harder part to solve when we are talking about implementing digital health. But I hope India is, since it's on the right path, I hope it also takes into consideration this part about digital health adoption. That brings me to my last question, and I understand that we have spent most of this conversation doing the hard talk, but I want to end with a very forward looking question, sir. If you were to paint a picture of what India's rural healthcare landscape looks like 10 years from now, with digital health having delivered on its promise, what does that world look like to you? And what is the one thing we must get right in the next 2 to 3 years to make that future possible?
First thing, Aarti, I would like to say that digital health will not be judged by how advanced it is, but by how inclusively it works and what mark it leaves behind. So, all these in time that we have been talking, the things that we have been trying to say that these things should be implemented, incorporated. If these things happen and we get all these right and we move in the right pace, direction is right. We need to move in a little better pace with a disciplined approach and little depth. If we have all of this, and then we will find that the rural healthcare will be connected, continuous, and far more equitable than what it is in today's world. I would say that we will see a scenario where a patient doesn't have to travel miles to get their basic healthcare. Care will be received far closer home, rather than traveling longer distances. Primary centers will be digitally enabled and connected and acting as a habit of continuous care. That will happen. Teleconsultations will become a routine and they will not become exceptionals. As of now, eSanjeevani teleconsultations are not happening continuously. So they will become a routine. This is what I foresee if we move in the right direction. I mean, in the directionally correct, but in the right pace and with honesty and integrity. We have to think inclusively about the people lagging behind in because they are our population. 63% of our population, as you said, are still there. So we don't include them in our healthcare system, we will continue to lag behind. But if we follow this, I will say that, as I said, inclusivity has to happen. Teleconsultations will happen, become routine. People do not have to travel longer distances. I'm sure that healthcare will be very closer to their home. They'll feel much empowered. Health records will become far more digitalized. They'll become portable and accessible. Like I just spoke before this, that PSCs are interconnected. PSCs are connected with the area health so that they can quickly access the digital data of these patients when they go there for treatment. And most importantly, empowered frontline workers. I keep on saying this. Unless and until we empower them, things will not move. So I hope to see that the government takes measures and steps to empower these frontline workers, train them, empower them, incentivize them, so that they work with a lot of motivation and dedication. So I see this happening. I'm optimistic, and I'm sure you also would be. And AI enabled early diagnostic at Vijay, as you said, just the previous discussion was about AI. So AI enabled, early diagnostic at village level will happen. Care will not depend on geography, but will depend on need, and it will
Hmm.
be taken care by need. Most importantly, rural patients would experience continuity of care. They will have dignity of care, right? Care will be consistent, persistent. So
Right.
invest in all of this and empower the frontline workforce. I think that is the primary underlying statement of mine. Empower the primary and the frontline workers, and I think things will move in the right direction in the right pace. Because if the last mile is weak, the system will not hold. And as
Absolutely.
I said, technology will succeed only when people are capable.
Hmm.
Technology alone will not help. So people have to be capable of using these systems. So if people are capable, supported, empowered, motivated, I'm sure things will improve. And that is what I see in the next 10, 2, 3, or 10 years from now.
And I think we are all optimistic about it. I mean, optimism is what
Right.
drives kind of larger scale intervention planning, optimism about it. And thank you so much for voicing the alarm. It is always good, while we are also optimistic about something, we also have to be critical about it and honestly look at the picture from a macro level to see what is going wrong and course correct at the right moment. So I think this conversation was all about that, to find out where the gap is, what is being done, what is being not, and what we can do to improve the access to the rural India, as we call, not only building for India but also building for Bharat. That's what I think this conversation was all about. Thank you so much for your time, for your
Thank you,
honesty,
Arti.
and
Thank
for
you.
the details that you
I have been
presented.
passionate about this particular subject. Why? Because I have myself traveled so much into the rural area and I've seen people suffering that it, and when I come back to the corporate sector and see, how much people have got, and when I reflect back and I see how much people are left behind, it pains because
Right.
we all are responsible citizens. So
Right.
I feel that technology by itself will not solve the problem. We have to
Hmm.
enable the technology to ensure that it is gets used properly across the complete spectrum of the Indian healthcare, rural, urban, both.
Hmm.
And this
Hmm.
transformation will come only we thoughtfully integrate it, effectively empower the people, and how deeply we build trust amongst people to use this system. Trust is very important, which you have spoken of. So we have built this system in that way. So healthcare is not delivered by systems or platform because
Right.
healthcare is delivered by people. And I keep
Hmm.
saying this to everybody, it is the man behind the machine that matters most. Thank you very much.
100%. Thank you. Thank you so much, sir, for your time. And to everyone
Pleasure.
listening, if something in this episode sparked a thought, a question, or even a quiet discomfort, sit with it, share it, because that's where the real change begins. Thank you so much
And
for
anybody
joining.
is,
Have a good day.
thank you very much. And anybody can connect with me to, discuss it further. I'll be more than happy to discuss it.
Absolutely. Thank you. Thank you
Thank you
so
very
much,
much,
sir.
Aarti, for giving me this opportunity to interact.